Welcome to This Week in Health IT News, where we take a look at the news which will impact health IT. This is another field report where we talk with leaders from health systems and organizations on the front lines. My name is Bill Russell, healthcare CIO coach and creator of This Week in Health IT, a set of podcasts, videos, and collaboration events dedicated to developing the next generation of health leaders. Are you ready for this? We're going to do something a little different for our Tuesday Newsday show next week. We're going to go live at noon Eastern, 9 a.m. Pacific. We will be live on our YouTube channel with myself, Drexta Ford, Sue Shade, and David Muntz with Starbridge Advisors to discuss the new normal for health IT. With you supplying the questions with live chat. Also, you can send in your questions ahead of time at hello@thisweekinhealthit.com. I'm so excited to do this, and I hope you will join us. Mark your calendar, noon Eastern, 9 a.m. Pacific on April 28th. If you want to send the questions, feel free to do that. And you can get to the show by going to thisweekhealth.com/live. This episode and every episode since we started the COVID-19 series has been sponsored by Sirius Healthcare. They reached out to me to see how we might partner during this time, and that is how we've been able to support producing daily shows. Special thanks to Sirius for supporting the show's efforts during the crisis. Now, on to today's show. All right, today's conversation is with Dr. Lyle Berkowitz, a primary care physician for over 25 years, IT practitioner for Northwestern for many years, innovation champion and telehealth expert as former CMO and EVP for product strategy for MD Live. Also chairman for HealthFinch, an automation platform, workflow and automation platform for healthcare. Good morning, Lyle, and welcome to the show.
Hey, thanks for having me, Bill.
Yeah, I'm looking forward to this conversation. I mean, I'm sure you have seen these curves. I mean, the hockey sticks are now pretty prevalent. I've talked to a lot of health systems, and they talk about going from 40 telehealth visits a day to 400 or even thousands of telehealth visits a day. These really are extraordinary times, and we are going to focus in on telehealth for the next 15, 20, 25 minutes. And specifically, we're going to try to figure out what it looks like moving out of COVID-19, post-COVID-19. So, I'm curious. Let's just start with the basic question. We've introduced an entire country, even a world, to telehealth, many for the first time. Do you think this is going to be a tipping point for virtual care in our industry?
Absolutely. Yeah, it has been a huge tipping point. I mean, this is something that many of us have been arguing and pushing for decades. Think back on it. The very first phone call was a telehealth visit. Alexander Graham Bell called his assistant because he had burned himself. Help me, come over here, Watson, right?
Right.
We've been using virtual means of communicating with patients in various ways for a long time. And certainly with the technology that has advanced over the past few years, it's becoming easier and easier to do. It's really been a combination of reimbursement and perhaps regulatory changes and just social and cultural issues that have prevented us from moving further. This has become an inflection point. This, as they say, don't let a good crisis go to waste. This has shown us that the barriers were never technology or interest or need. It's been very much an inertia to not do things and reimbursement issues that have been overcome. It's a little like Dorothy in Oz. We've had the ability all along. We just had to click our heels.
Yeah, absolutely. And we did have some technology hiccups early on. I guess we didn't anticipate going from 40 to 400 a day and having to really ramp up that many physicians. It was pretty radical. And some of the larger telehealth practitioners actually, or telehealth organizations actually stumbled a little bit coming out of the gate in terms of that scale. I mean, what are your thoughts on being able to scale that quickly? Did we just not anticipate the infrastructure that was going to be necessary, or just didn't anticipate that kind of growth that quickly?
Yeah, so for the independent telehealth vendors, the issue is all about supply, demand, and volume. And no one predicted or could be prepared to essentially double volume overnight or within a matter of a week. Because the issue, I don't believe in any of the cases was technology as much as it was having enough physicians being prepared for the volume. And there's there's no clinic in America or anywhere that can just deal with doubling overnight of patient requests, but that's essentially what they had to do. At the health system level, what was interesting is they had patients scheduled already, so they call patients, contact them, and explain to them, we're going to do your visit online now. That could be a phone visit, could be a video visit. I do think that the health systems probably stumbled a bit if they were trying to do video visits, because that implies a technical ability of the patients that often isn't there and requires a level of support. So we know the EMR vendors and the telehealth vendors in the technology space and the health systems themselves did probably struggle with the technology side of video. A number of folks I talked to in the health system side just did phone. The issue at that point became what and how will they be reimbursed? Can a phone visit be reimbursed the same as a video visit? The change that came on the parity type laws were that definitely a video visit could be reimbursed similar to an office visit. There's still, I think, questions as to whether phone visits can be. Some are interpreting the new rules, regulations, and culture from both CMS and commercial payers that yes, phone visits are acceptable and they can bill at a office visit level. Others are using the phone-based codes, but those are incredibly less financially viable as compared to the office-based.
All right, so you took us in the reimbursement direction, so I'll take us in the government response to this, sort of setting up how we sustain this. Over the weekend, this just some stuff that pulled out a story. So the quote goes, I think the genie's out of the bottle on this one, says Seema Verma, CMS administrator. I think it's fair to say that the advent of telehealth has just completely accelerated, and it's taken this crisis to push us to a new frontier, which is essentially what you're saying. There's absolutely no going back. Lawmakers might worry that permanently easing access could increase spending, and that effect will no doubt need to be evaluated. But this, to me, Ms. Verma says, is the most clear example of untapped innovation. All right, so if you were coaching Seema Verma at this point, what are some things they need to put in place in order to sustain the gains that we've gotten from a telehealth perspective, and an access and an ease of access to care that we didn't have prior to this?
So first, big credit to Seema Verma, and this is not new. She has been advocating and a fan of telehealth virtual care for the past couple of years. I've been in meetings with her. She has been a fantastic champion for this, and love to hear that type of quote. The number one thing that has to happen is that the reimbursement changes need to continue, and they need to be more clear. Essentially, we have to make sure that we are paying doctors appropriately for their time and their intellect in taking care of patients, whether it's in the office or online, whether that's phone, video, asynchronous care, etc. Now, that said, it's still a fee-for-service world in many cases, and so that implies more volume, and that's always what the payers have been worried about. The government can only, remember, set the CMS rates. Now, the commercial payers need to follow that. So no matter what Seema Verma says, that apply to CMS, but the commercial payers need to follow suit, and that's what we certainly hope they do. And in fact, if they do that, the good news is, there's still documentation standards that have to be done. We're not going to, doctors aren't going to bill for a simple, 1-minute phone call that isn't documented. It's got to have some actionability. What we found, also at MD Live and other telehealth vendors have found, is substantial savings in care, because if you provide fast and easy, convenient access to people, they're going to decrease the need to be in the urgent care and emergency room. And that saves a lot of money and frees up the system to take care of people who really need to be there. And it's both being able to do it in a quick, easy way, but it's also quicker access. So now you don't have someone waiting until they're super sick and need to go in and see the doctor or go to the emergency room. If we can catch them a little earlier, manage them better, it does save money and improve.
Yeah. So the thing about the government is they're worried about. I assume they're worried about fraud and increased cost. So, how do you address those two things? How do you address the fraud aspect, and how do you address the concern that there's not going to be enough money to pay for something like this?
Yeah, fraud and abuse is an issue, whether it's office based or virtual based. And what's good is that they've gotten better at rooting this stuff out. And there's certain areas that have been probably more ripe for fraud in terms of medical devices, compounding meds that they have gone after successfully. And I think these days with computers, artificial intelligence, etc., will probably be easier to find the outliers who are doing it. It's as usual. It's a couple bad apples. It is you don't want to proverbially throw the baby out with the bathwater. The vast majority of doctors are wonderful, kind, caring humans who are going to do this appropriately. And I think it's going to be easier because of technology to find the doctors who maybe are trying to abuse, but they would abuse in the office as well as virtually. So it's silly to just say we can't support virtual care just because it's virtual when it's really the individual that we have to look out
for. All right. So, when a crisis hits, a few things happen. We react, we sort of stabilize that environment, and then we reimagine it. And we reacted with a bunch of makeshift solutions, and we scaled some of the industry leading solutions that have been out there. One of the questions I'm getting from a lot of people is, okay, we threw things at it. We threw FaceTime at it. We threw Zoom at it. Some of the more advanced health systems already had MD Live, American Well, and others, and they scaled those up. But the ones who put things in place, they're now saying, okay, is this the new norm? And if this is the new norm, it's how do we transition from this makeshift? What does a well-designed telehealth or at least virtual visit platform look like for a health system?
So this is where in the innovation world we talk about rethinking the problem, understanding what problem we're solving, and this is I think been a fundamental issue or flaw that I've been arguing for years in the telehealth industry needs to think is what problem are we solving? We have to move away from that. The problem has traditionally been how do we replace a 15-minute office visit with a 15-minute video visit? That's an important problem. It has its place. It is beneficial, but it in the end is not reimagining here, and it's not something that can scale. So what we really need to think is rethink the problem. If the problem is how do we take care of someone with a routine, repeatable, not a type of issue, in as safe and effective, high quality, low cost way as possible, that problem opens up a whole new world for us that involves not just video, but any type of virtual care and automation. And it's a combination of automation and virtual care that will allow us to scale and manage many more people in a really high quality, cost effective way. So what we're starting to see, for example, is the use of front end chatbots to triage and collect information ahead of time. So by the time you get to the doctor, most of your note and most of your process is complete. Hypnosis example of a company that's been very successful at doing something like that, and most of the telehealth companies and the EMR companies have some level of that, but the ones who do that really well will succeed the most. Second is asynchronous care. Not everything has to be live and or video, right? If the goal is taking care of someone, the goal shouldn't be doing a video with someone. And the truth is a lot of patients don't like video. In fact, at a lot of the telehealth experiences out there, you'll find much more phone care than video care, combination of convenience and comfort level. And in fact, asynchronous allows for an even better scale of use of physician resources, where the patient will fill something out online, and then the doctor will be able to review it. And ideally, you'll have some level of technology that reviews how that works, so that the bottom line is the patient can do the care on their time frame. The physician can do it efficiently, and the end result is that you have a a very efficient visit that's high quality. And eventually, I would imagine you don't need a doctor. For much of the routine care that we do, it can and should be automated. This is where talk about the next level of government's FDA approval for simple stuff, sinus infections, UTIs, etc. These are pretty routine, evidence-based, algorithmic-based problems that can be solved probably without necessarily having a doctor involved, unless there's an issue that needs a doctor's review. Similar to other industries, you don't escalate to the highest paid person unless there's something abnormal going on.
So you're a primary care physician for 25 years, and it's interesting to hear you talk this way because it essentially really changes that game. You gave a talk at I think the Health Catalyst Summit where you talked about reimagining the number of visits that a primary care physician could handle, and I think it was like from 2,500 to 25,000. Or am I getting those numbers right?
So yeah. What if we 10x healthcare? But the goal is not to increase the number of visits a doctor sees; it's the number of patients that they can manage. So how can a typical primary care doctor manages a panel of 2,500 patients? What if they could manage a panel of 25,000 patients? What would it take? And it would. What I talk about is my SAD and FAT philosophy. It's a combination of simplify, automate, and delegate routine, repeatable care, and then use financial incentives, automation, AI, teamwork, and telehealth to operationalize more care. And two of the key things there are teamwork, so delegation of more of the care to team members that are empowered by technology, like HealthFinch does that by telling staff how to refill and using protocols and rules appropriate for the patient, so you don't have to bother the physician. That we save 1 million minutes a week of physician time by helping to automate and delegate that care. And then I think we'll even move more to pure automation for a lot of routine care. If you think about the pyramid, right, of patients, 80% of patients have routine, repeatable type of issues that we can probably automate, similar to, again, how other industries have used the online self-service automation. So that if you have hypertension, diabetes, if you have a sinus infection, as long as you're staying within the lines, we should automate it. This is how we're going to save the healthcare system. So, because we currently don't have enough doctors to take care of all the patients in our current paradigm, which is a blockbuster like bring everyone into the office. And taking those visits and just putting them online isn't enough. We have to automate it further so that the typical doctor can take care of more patients in the panel with his team, but actually only needs to see a smaller number of patients. Another way to think about it is taking the doctors and converting some doctors into simplexologists, where they're doing the care online and overseeing computers and other staff, and complexologists who are taking care of the really, really sick people, and therefore they have a much smaller number of people that they're managing who really need their care. Yet to be seen whether we have to divide those out or the same doctor can manage all that. But bottom line is we have to do what every other industry has done in using IT automation to manage more routine type of care, because that's how we get to the point where we have enough doctors to take care of everyone. I'll often say we don't have a shortage of doctors, we have a shortage of using them efficiently. And the more we can use technology to enable automation, the easier and quicker we'll get to the point where everyone's going to get the care that they need in a cost-effective way.
All right. So last set of thoughts here, and it's really around the healthcare environment has been hit pretty dramatically, right? We know that a lot of health systems right now are losing money a fair amount. I mean, they're not doing the elective surgeries and those guys. There's a lot of things that they normally do that they're not doing. The surge really hasn't hit in a lot of places, and so there's a lot of empty beds, quite frankly. So the financials have been hit. what if you were consulting with a healthcare organization right now, not necessarily the payers, but the providers, um, is there an opportunity to rethink this coming out of it, or is it going to be more of they're going to still be in a react mode because they're going to be reacting uh, to a whole bunch of lost revenue that they have to figure out how to plug holes at this point?
Yeah, and right now, I think most health systems are understandably focusing on the here and now. How are we going to take care of everybody in a safe way, stay in business, etc. And that's appropriate. But they also need to start thinking about creating a team to think about the future. In 3, 6, 12, 18 months, where are we going to be? How are they going to be prepared? I think the way I'm working with health systems is start thinking about future scenarios. Where might the future be? I think the biggest issues, if I'm going to look at, is one, where are we going to be with COVID? Are we going to be past COVID, or are we still going to be dealing with it in a lot of ways? And I would say on the other axis, I'd look at, are we reimbursing for virtual care? Has that happened, that we have continued reimbursement at a parity level? And then those create 4 quadrants, and for a health system to start understanding for each of those quadrants, what's my strategy for each of those, and what are the milestones that I need to start looking out for to understand which quadrant is most likely. And in any quadrant, you're still going to be reimagining care. This is also where value-based care becomes incredibly important. If you are in a value-based environment and getting paid per member per month, you're in a much better situation. And in fact, a really good situation, because you're you're still getting paid, but doing less of the care. I also think there's going to be a big push and need for consolidation, as doctors' offices, particularly private doctors, are going to go bankrupt without the support of larger health systems. We're going to see what type of money the government's going to need to bail out. I mean, they bailed out the banks in the past. They better damn well bail out the hospital systems, who are, a true backbone of America, as well as medical groups to stay afloat. And then long term, we have to rethink, we have to really rethink how, again, we automate and virtualize care, and then rethink how we pay for care. And those are certain discussions that are made at the local level, certain that are going to be done at the government level that need to be followed really closely. And the hospitals and health systems need to advocate for themselves.
Yeah. So, Lyle, this has been a great conversation. I really appreciate it. But my last question is just around the consumer, right? The consumer of healthcare. How have they changed? I mean, I assume there's some expectations that have changed, and I assume there's also their behaviors are going to change. I know that you can't go for even 2 months and tell people no visitors in the hospital, and you've created this environment where people are a little concerned about not practicing social distancing and going into the hospital. How are we framing? How are we thinking about the changes that have gone on in terms of the consumer and what their expectations are going to be coming out of this?
Well, interestingly, I think consumers have been looking for this for a long time. When we saw some of the comments at MD Live from patients about their satisfaction with the system, one of the common threads we would always see is people saying, I really love this service, it's fast, easy, etc., but I hate going to the doctor's office. There are all those sick people there, and I don't like being in a room with sick people. This is well before COVID. They knew that the current system wasn't great. Don Berwick, the famous doctor in quality, called it the tyranny of the office visit. It's inconvenient. It's health risk for your health has been around for a long time. We as primary care doctors knew if someone came in for a checkup and they were in a room with, in a waiting room with sick people, they'd be back in a few weeks. Not a good situation. So I think consumers have been looking and asking for this. They just were not sure how it's getting paid for, who's doing it. They want to do it with their doctor if possible, but for minor things, they may do it with anybody that can do it. So I think that we've broken the barrier, and we've shown both doctors and patients this is easy and feasible. Most doctors I talk to, they're like, you know what, this isn't as hard as I thought, and my patients love it. Think about every other industry. I often use Blockbuster and Netflix as an example. Blockbuster insisted that people love coming into the office, into their offices, into their buildings, playing with the DVDs, talking to staff. No, what problem should they have been solving is people want some type of media. Netflix figured out how to do it easier and cheaper, more conveniently, and it worked very well. Healthcare industry needs to take a lesson learned from that. Just like, Bill, when we were young, we used to have to go to the bank and talk to someone to get money, right? That doesn't happen anymore. In the same way, healthcare has to learn from that. On the inpatient side, I'm on the board of a company called OneView that does inpatient software in the patient room, and they quickly had rolled out software that helps with virtual rounds, with your doctors and nurses, and virtual visits between a patient and their loved ones, which quite honestly there wasn't a ton of interest in before, but became very important very quickly. Virtual interpreters too. That type of software in the hospital setting will just become standard as people need to get isolated more. I mean, we live in a different world now, but we have the technology to do it. We just have got to get over some of the cultural inertia in healthcare that takes time to change, but you've done it now.
Absolutely. Lyle, thank you for your time. I really appreciate it. You're sheltered in place. Where are you located out of?
I'm in Chicago.
You're in Chicago. What's the situation like in Chicago these days?
It's quiet. It's beautiful out. People are still out walking, being active. As the weather gets nicer, Chicago is the type of town where everyone loves to go out. So I think they're going to struggle a lot as we get into May and the weather gets better. But everyone's being very respectful of each other, keeping their distance. The studies show it's very hard to spread an outdoor space. And this is a tourism town, though. It's hurting. There's a lot of people in the hotel, restaurant, and convention industry. And they're suffering right now. So we're hoping the right balance comes along. The hospitals here have been amazing. They have prepared excellently. They have expanded their ICU ability. We've opened up at our convention center at McCormick. They've opened up a temporary hospital if needed. So we are over prepared, but we'd much rather be that than it's like my family. We always have more food than you need at a holiday celebration. So it's the same thing. Here we are really prepared for potential onslaught. Our ICUs would have been overfilled if we didn't expand, but every hospital I've talked to has prepared well, and because of our relatively quick and aggressive move and stay at home, we seem to have flattened the curve. I think the angst is over the extending into the end of May. The governor is pushing for that. Business people are getting pretty worried about that and trying to figure out where the right compromise is. And we'll be watching, I think, everywhere from Sweden to Georgia to see how that works out and see if there'll be some balance that lets us get back to a little more normalcy and lets people get back to work.
Yeah, absolutely. Lyle, again, thank you for your time. I really appreciate it.
Okay, thanks, Bill.
That's all for this week. Special thanks to our sponsors, VMware, Starbridge Advisors, Galen Healthcare, Health Lyrics, Sirius Healthcare, and ProTalent Advisors for choosing to invest in developing the next generation of health leaders. If you want to support the fastest growing podcast in the health IT space, the best way to do that is to share it with a peer. Send them an email, DM them, whatever you do, however you do it. Go ahead and do that, and that would benefit us greatly. We appreciate your support. Please check back often as we will continue to drop shows until we get through this pandemic together. Thanks for listening. That's all for now.